Hello, I'm Angela Hogan from Norfolk, Virginia, and the title of this presentation is Want a New Drug, One That Won't Make Me Sick. Focus on drug allergies. This is my disclosures. I am on the Speakers Bureau and Pediatric Advisory Board for two different pharmaceutical companies, but they have no reflection on today's CME approved lecture. So our objectives today is we want to learn about drug allergies and how we classify them, and then we want to dive a little bit deeper into immune-mediated adverse reactions to drugs. And then we want to be able to learn what questions we need to ask to help us understand, is this a true drug allergy or not? And then we want to think about what we can do to optimize giving a patient the safest drug possible. So when we talk about drug allergies, there's different ways to characterize adverse reactions. An adverse reaction is a general term that applies to any unwanted reaction that occurs with a medication. Adverse drug reactions can be broadly divided into two different types, type A and type B, and we'll go over those in just a second. Drug hypersensitivity reactions are reactions that result from unintended or unwanted stimulation of immune cells or happen because of inflammation by those cells. So these are type A reactions. Type A reactions make up about 85 to 90% of all adverse drug reactions. These are reactions that occur in most normal patients. If you give them too much or you give the drug long enough, then you can see these kinds of reactions. They're very common and they're very predictable. It would be something like an overdose or possibly side effects. Maybe you gave glucocorticoids and you might see thrush because of that. Or sometimes we see diarrhea when you have antibiotics in the face of a GI infection. Or perhaps they may be drug interactions like macrolides and theophylline. Those are type A reactions. Type B reactions make up a much smaller percentage of drug adverse reactions. Type B reactions make up about 10 to 15% of adverse reactions, and they only occur in susceptible individuals. These are usually signs and symptoms that are different from the pharmacological properties of the drug. They're often mediated by immunological cells or inflammatory mechanisms. That's where our drug hypersensitivity reaction falls. And we also see idiosyncratic reactions falling there also. These are much more rare and unpredictable. And examples would be like people that get ringing in their ears after they've had aspirin, or perhaps patients that get hemolytic anemia after they've had dapsone. Or this is where the thing that most of us think about for drug allergy, anaphylaxis or IgE-mediated reactions fall. So there's lots of different ways to describe adverse drug reactions or drug hypersensitivity reactions, and we're going to spend just a few minutes trying to understand ways that we can explain these reactions that might help us understand the mechanisms of the adverse reaction better. So the World Health Organization says that the first thing to do is to divide the reaction either into an immediate reaction or a delayed reaction. And the time period they use is 1 hour. So individuals who have a reaction to the medication within 1 hour are more likely to have an IgE-mediated type reaction, a type 1 Jelen-Coombs, which we're going to spend another moment talking about. And then delayed reactions are everything else. They can happen from days to hours, and this is where our Jelen-Coombs other types of reactions fall. So let's look at Jellicoes because they're a great way to look at drug allergies. And if you remember, there are 4 different types of Jellicoes reactions. The first type is type 1. The prototype of that is anaphylaxis. They're immediate onset. They are mediated through IgE molecules that are on the surface of the mast cell. They see the drug antigen or allergen. They bridge the IgE molecules and then they release the mediators, and those mediators cause the immediate reaction. Remember that IgE can be on the surface of basophils also. The second type of Jellicoes reaction is a type 2 reaction. This is the reaction where the actual allergen is now on the surface of the cell, and then antibodies recognize that antigen or allergen, and then in that process the antibodies leave open an opportunity for complement to come and attach to that, and then we see cell-associated membrane complement activation and mediated cell destruction. And usually these are IgG or IgM antibodies, and this is a cytotoxic reaction. Type 3 reactions actually are very similar, only instead of happening on the cell surface, the antibody is now free in the serum. It recognizes the drug, antigen, and then complement again finds it and makes these complexes that can either be deposited in tissue and lead to complement activation and inflammation. And this particular reaction is a delayed type of reaction. And then the fourth type of reaction is even more delayed in onset, and this is considered to be a T cell mediated reaction, which interestingly, when Jellicoes first described it, we did not know that all the different types of T cells existed, but it has stood the test of time, and what we know is that there are multiple different type 4 reactions that are now divided into different subtypes based on what kind of cells are involved in those reactions along with the T cells. So, and in this particular example here, you can see a sensitized T cell that takes up the antigen and processes it, and then actually has inflammation implemented through the reaction of the macrophage. So here's kind of a big overview of all of these again. Again, the prototype for type 1 would be anaphylaxis. The prototype for type 2 would be a thrombocytopenia. The prototype for type 3 would be serum sickness. And the prototype for type 4 is our contact dermatitis reactions. It's important that we understand those different mechanisms because drug reactions obviously can present in any of those different ways, and how we manage them and the future risk for other reactions depends on what the mechanism is. So let's move for just a few minutes now to hypersensitivity drug reactions, which we think are more IgE mediated as we move forward in our discussion. So what do we know are the risk factors for developing an IgE mediated reaction to a drug? Well, some of it has to do with the properties of the drug. What's the molecular weight of the drug? How many metabolites does it make? How easily do metabolites bind to self-proteins to form hapten protein complexes? It also depends on how much we give. We know higher doses of medications are more likely to lead to IgE-mediated reactions. Whether or not we give it IV versus oral, IV seems to lead more towards IgE-mediated reactions. And then there are some host factors also. We know that for whatever reason, the female gender is more likely to have drug allergies. Also, if you've had a prior history of an allergic reaction to something else, we know that there are certain HLA types that are associated with IgE-mediated reactions more likely, what the infection is with, and then we also know HIV-infected individuals are more likely to have IgE-mediated drug allergies also. So, true drug hypersensitivity reactions are uncommon, but many children are labeled as being allergic to drugs especially antibiotics. The prevalence is about 7% of the general population, and we know that drug hypersensitivity reactions in children look very much like they do in adults, at least for beta-lactam antibiotics, NSAIDs, several other antibiotics, and also acetaminophen. We know that there are often misdiagnoses of drug allergies, both underdiagnosis, but probably more commonly overdiagnosis due to other factors that may be present. Most commonly, we see a drug rash, and they also have a concurrent infection, and the virus is actually causing the rash, but because they're on an antibiotic at the same time, then they oftentimes get labeled as having a drug allergy, when in fact it's just the virus. And then there's the misconception that many patients hold that if you've been diagnosed with a drug allergy, that that's going to be lifelong, and that's something that even though it was diagnosed as a baby, you're going to carry that diagnosis forever. So let's approach the patient that we think may have a drug allergy, and what kinds of questions would I want you to ask to sort of get a better understanding of it. So the obvious first one is, what were the signs and the symptoms that the patient saw when they first had the reaction? How long ago did the reaction take place? How severe was it? Did they require hospitalization? Did they require epinephrine? Did they require steroids? Why were they being treated with that medication? And then, of course, what was the route of administration? Was it given orally or was it given IV? And then, had they ever taken the medication before so that they would have had an opportunity to be sensitized to it? It's unlikely to be an IgE-mediated reaction on the very first exposure to that medication. Other things that you may want to think about if you're trying to decide, was this a drug allergy? Did they have another medication that was started at the same time, or was it a medicine that they'd been on for a very long time? You want to know about the timing to the onset of the reaction. Did they have the reaction within 20 minutes of taking it, or did they have the reaction several hours later? Also, you want to know what day they were in the course of it. So they were on amoxicillin day 6 versus amoxicillin day 10. Those kinds of things help us understand whether or not the likelihood of an IgE-mediated reaction is there also. And then you want to know, had the patient ever had the medicine since they had the reaction? Because obviously if we think it were an IgE-mediated reaction, they should have that reaction every time they get the medication if it's a true allergy. And then we want to know, have they had any medicines in that class before? So if someone told you that they'd had an allergic reaction to Augmentin, but they'd had amoxicillin since, then you would be more suspicious that that probably doesn't fit with an IgE-mediated reaction. So when you're evaluating the patient, you want to review the medical records so that you can get a good timeline of the reaction. You also want to look to see if there were any other co-founders like fever, or if they happen to have had laboratory studies done. Did they happen to have eosinophilia at the time that they were having the allergic reaction? You also want to know, when was this reaction noted? The further and further in time they get away from the reaction, there's a possibility that they may have lost their sensitivity to that drug, and that perhaps their likelihood of reacting to it is lessened. So I think that is important to figure out what the exposure timeline is. You always want to try and document the rash if you see it. Oftentimes today my patients will bring me a phone picture and I'll get to see the rash, even though it may have been several months or even sometimes several years earlier. And what you want to do when you document the rash is you want to describe it. So I put for you what I sort of think is Dermatology 101 and how to describe rashes. I usually try to document the shape of the rash, what's the size of the rash, whether or not they are macules or papules or vesicles. I try to usually describe if they're well demarcated or just kind of blend into the tissue. I also usually try and describe the color and certainly the distribution. But as an allergist, the most important question that I'm going to ask is, were they hives or not? Because hives for me mean I have to do a more extensive workup, and then it's more likely IgE mediated, and it's more likely that this could be a drug that we might not be able to use for some time in the future. So then you would like to know, is there any particular objective tests that are available that might help us know whether or not this was truly a type 1 or IgE mediated drug allergy? And there is skin testing available, and skin testing has been validated for several drugs, and we'll go over that in just a minute, but it's not for a lot of drugs. And these particular tests, while widely used, they're not always standardized, and they're not validated. We oftentimes have to understand what concentration of the drug would cause an irritant reaction in everybody, and have to skin test with much lower concentrations in order to get a truer test result. We know that there are some in vitro tests that are available, but many of those are investigational and not always correlating with the drug allergy history that we might be getting from the patient. So there are not a lot of good tests. Now, if you have a type 4 reaction like a contact dermatitis, patch testing can be helpful and is widely reproducible. But for type 1 reactions, it's a lot more tricky. If someone presents to you in the acute time period and you think they might have had an anaphylactic reaction, sometimes we order tryptase levels. Tryptase is a mediator that's inside the mast cell and basophils, and it is immediately released when the cell is triggered. And ideally, if you could grab a tryptase level at the 30-minute to 3-hour mark after the episode and it's elevated, then that can be helpful to predict that they did in fact have anaphylaxis. But sometimes it rises a little bit, but not that much, so sometimes we need to have a baseline level also when they're healthy so we can compare the two. And sometimes there can be anaphylaxis to some things and we just don't get the elevated tryptase level in enough time, or sometimes for things like food allergy, for example, we don't always see an elevated tryptase level with anaphylaxis. So if it's elevated, it's helpful. If it's not, we'll have to go on history still. So let's spend just a half second about what we do as allergists for skin testing and what you could expect if you refer someone for that to try and sort out a drug allergy. Skin testing measures IgE mediated, so it's only helpful for type 1 reactions. What we do is we look for a positive wheal and flare about 15 to 20 minutes after we've done the skin test. But the tricky part about it is that there are some drugs that people have reactions to the metabolites. And so we may not always have the metabolites available for skin testing. We may only have the whole intact drug available. Fortunately for penicillin, we do have some of the breakdown products available. We have major and minor determinants, and we have pre-pen, and that can be very helpful for us to understand the penicillin allergy a little bit better, but we don't have it for a lot of other drugs. And then there are some drugs that actually directly cause the mast cells to degranulate. These are usually your narcotics like opioids, sometimes even vancomycin. If we try to test to it, it gives us a lot of false positives. So it's a little bit tricky, but there are some resources that say there are some drugs you can test. So drugs that you can test, for example, are things like penicillin, the perioperative agents, local anesthetics. We can test insulin. We can test corticosteroids. Sometimes we can do biologics, but almost never are we able to test things like antihypertensives or the lipid-lowering agents or seizure medications. The one that's sort of the standard and true is penicillin. And what we can do is do this test very rapidly in about an hour or two. It's very cost effective and causes minimal discomfort to the patients. So when we have patients that we think have a low likelihood of actually having a drug allergy, then the next step that we do is a drug challenge. And what a drug challenge is actually exposing them to the drug, first in a small amount, a dose that we think would not cause a serious reaction. And then if they do fine with that dose, then we either do incremental increases, or sometimes we just go ahead and do one larger dose to make sure that they can tolerate the full dose. So in my clinic, I usually do penicillin testing, and when the penicillin testing is negative, then I move ahead to an oral challenge to make sure they can tolerate the medication. So let's look at a practical application. The patient I'm going to share with you is Giselle. Giselle's a 10-year-old female who as a toddler had many ear infections and needed PE tubes at 18 months. Mom was recently on the patient portal looking at Giselle's medical record and wondered about the penicillin and sulfa drug allergies that were listed there. Mom states she personally has a significant history of an allergy to penicillin and sulfa drugs also. When Giselle was 2 or 3, she had a rash that occurred somewhere between days 2 and 4 of an oral course of amoxicillin. She'd previously tolerated the amoxicillin before. Mom remembers the PCP told her that she probably was having an allergic reaction to the amoxicillin and switched her over to azithromycin. Mom states it took 3 days for the diphenhydramine to work and make the rash go away. Mom states she can't remember if the rash itched before she was on the diphenhydramine. So first of all, she's 10 years old, and this particular reaction happened 7 or 8 years ago. Also, the fact that Mom has a drug allergy doesn't necessarily mean that Giselle is at a greater risk for having a drug allergy. She had previously seen the amoxicillin before, so that does increase the possibility of a drug allergy a little bit. And she did have the rash early in the course of the amoxicillin. But she didn't really seem to respond to the diphenhydramine, and normally IgE-mediated reactions we see respond much more quickly to antihistamines than what she did, so that sort of doesn't support an IgE-mediated reaction as well. And almost always, drug-mediated IgE-mediated reactions, they itch. And it doesn't seem like that if Mom doesn't have a memory whether or not the rash itched very much, that this was probably a particularly itchy rash. I always ask them to describe it for me. Did it look like mosquito bites? Did it go on to bruise or leave any kind of a lesion? We know that IgE-mediated reactions don't leave a mark after they have resolved. So there are some things in this history that could go along with an IgE-mediated reaction, but there are things in this history too that make me think, maybe not. Newsflash, true penicillin allergy is really not very common. Penicillin allergy is the most commonly reported medication allergy in up to 10% of patients and up to 15% of hospitalized patients. It can develop at any age, and it is often misdiagnosed. Again, as I mentioned, it's usually a viral exanthem that's called a penicillin allergy because it happens concurrently. Misdiagnosis with a penicillin allergy can lead to inferior microbial coverage, increased side effects, increased cost, and ultimately lead to the development and spread of certain types of drug-resistant bacteria. In reality, less than 2% of those patients with penicillin allergy actually have an IgE-mediated drug allergy. That means that more than 30 million people in the U.S. are mislabeled as penicillin allergic. So let's talk just for a second some more fun facts about penicillin allergy. Anaphylaxis occurs in about 1 to 4 episodes of 10,000 administrations of penicillin. And anaphylaxis with amoxicillin, 1 in 200,000 administrations. We know that frequent, repeated courses of penicillin seem to favor the development of IgE sensitization, and as I mentioned, IV dosing has a higher rate of sensitization than oral dosing and a greater risk for anaphylaxis. While genetic factors may play a role in penicillin and other antibiotic allergies, first-degree relatives of patients with penicillin allergy do not need to empirically avoid penicillin or penicillin-type products. Atopic patients do not appear to be at a higher risk for developing penicillin allergy. And the primary immune response is directed at the antigens from the breakdown or the metabolites of penicillin. Most of the allergy antibodies are directed to the core structure of penicillin or the penicillin ring, and much less commonly towards the side arms. This is an important fact. 50% of patients with IgE-mediated penicillin allergy have lost their sensitivity 5 years after the reaction. So 5 years out, 50% are no longer penicillin allergic. And 10 years out, 80% are no longer penicillin allergic. So let's look at penicillin by the numbers from a very nice composite study that was published in 2020. It was from the Kaiser Permanente Southern California Healthcare Plan, and they collected all penicillin use between 2009 and 2017. And of all the courses of penicillin that were written, they identified all the episodes of anaphylaxis that were associated with penicillin class antibiotic use. They looked at the route of administration, and each case was then manually reviewed in order to verify that each case had anaphylaxis and that a penicillin derivative antibiotic was in fact used. And what they found during that time period, there were 5 million courses of oral penicillins given to 3 million individuals, and that 33,000 or 0.6% of them reported a new penicillin allergy. And 22 cases out of the 5 million courses had confirmed anaphylaxis, or a rate of 0.065%. So the odds of having anaphylaxis to a course of penicillin or penicillin derivatives is pretty low. What they also found is that if approximately 0.1 to 1% of all penicillin exposures result in a new allergy report, less than 1 in 1,000 penicillin allergies actually result in anaphylaxis. They also reported in their paper that in Great Britain, during a 35-year period, more than 100 million amoxicillin courses were given, and there was 1 fatality noted after oral amoxicillin, and 7 additional deaths associated with parenteral or an unknown route of amoxicillin exposure. So that's 1 death in 100 million courses. So the odds of dying from this particular drug are very low. So what is the best approach to take when you are thinking about someone who needs to have a penicillin derivative for their infection? So first, you've reviewed the history, you've looked at the EMR, you've classified the reaction, and if you know in fact that it's a non-allergic reaction, then you can go ahead and treat them as you would like, just advising them about the adverse effects that can sometimes happen. And you want to go ahead and correct or clarify the medical record so that they don't in fact have penicillin listed as an allergy. But let's say the past reaction was mild. There really weren't any strong features of an IgE-mediated reaction. Maybe this is the classic macular papular eruption that may or may not itch. But the patient's chart does list it as a penicillin allergy, and the patient doesn't recall anything more about it. You'll do a risk assessment and decide whether or not you think there's a risk for it to be an IgE-mediated reaction. And if you think it could have been potentially, then you might go ahead and do a test dose, a drug challenge to make sure that that drug is safe. Or if you needed to decide a drug right then, you could go ahead and pick a third or a fourth generation cephalosporin, and that may make it very easy for you because you know those drugs are not going to be cross-reactive. If they have a type 2, a type 3, or a type 4 reaction, like a Steven-Johnson's or a 10 or a DRESS, you're just not going to use the penicillin drug at all. You can use aztreonam or an unrelated non-beta-lactam antibiotic. You want to avoid penicillins, cephalosporins, and carbapenems if possible. If they did have a past reaction that did have features of IgE mediated and it was anaphylaxis, then you're going to want to think about how long ago it was, whether or not you want to go ahead and do formal testing for them, or if you need a drug right now, you can do a third, a fourth, or a fifth generation cephalosporin and feel pretty safe about it. These particular tables are from Up to Date, and they have a nice, easy chart in there about the approach to the patient with a past penicillin reaction who requires a decision about antibiotics now. And it was very hard to read, so I had made it in a little bit larger print. So, if you think it might have been an IgA-mediated reaction, if the history says there's hives, then you need to skin test. And if the skin tests are negative, then you do an oral challenge. If you don't know and they can't really give you enough by history, then I always err on the side that they might have been hives. So I go ahead and skin test and then do an oral challenge if it's negative. If it's not an urticarial rash, and the pictures that they show me demonstrate that it wasn't an urticarial rash, then many times I move on to just do the oral challenge only. And so the standard oral challenge that we do in our clinic is we do a tenth of the dose, we wait 30 to 60 minutes. If they're doing fine, then we go ahead and do the rest of the dose and watch them for another 30 to 60 minutes. Obviously, you would be prepared to treat anaphylaxis if you were doing an oral challenge to a drug in your clinic. So if you're allergic to penicillin, you do not need to avoid cephalosporins. It's all about the base. What we know is that penicillins and cephalosporins share a common beta-lactam ring, and early reports in the 1970s said that there was some cross-reactivity between these two, but it was really because we think that in the production process, the cephalosporins were actually contaminated with trace amounts of the penicillins. The reaction to the beta-lactam rings was originally the explanation for this reaction, but in reality, more recent studies have confirmed that if there is any cross-reactivity between beta-lactams and penicillin, it's really more about the ones that share the same side arms or the R groups, and that tends to be where we think the cross-reactivity is actually occurring. People who are allergic to aminopenicillins, that's amoxicillin and ampicillin, have higher rates of cross-reactivity with cephalosporins, but again, it's because they share a common R group. So what do I mean by that? Well, here's an example of two penicillins that have the same R group, and these are the cephalosporins that have the same R group. So you're more likely to see cross-reactivity if you have a true allergy to one of these. Then these are the cephalosporins that you would be more likely to react to because of the shared R group between these two. And that's really the cephalosporins that we worry the most about when we're thinking about amoxicillin or ampicillin allergy. So here are the rates of actual cross-reactivity. If you're penicillin allergic and you want to give a cephalosporin, the risk of having a reaction overall is 3%, but higher in those ones that share the same R group. If you're amoxicillin allergic and you use cefadroxil, then you have a 27% chance of reacting to that. If you're penicillin allergic and you use a second generation cephalosporin, less than a 1% chance of reacting to the cephalosporin. If you're penicillin allergic and you use a third or fourth generation cephalosporin, you have a 0 chance of reacting to that cephalosporin. So it's really important in patients who have the allergy that they understand that there are many more antibiotics that are available, even though they're penicillin allergic, that can be used safely. And you can see there the rates for azathioprine and also for carbapenems are also here on this slide. So what's the bottom line? The bottom line is if you're a penicillin allergic patient, you can often be treated with cephalosporins and carbapenems without any concerns. More than 90% of patients with a reported penicillin allergy do not have IgE-mediated sensitivity when skin testing is performed. And even among patients with IgE-mediated penicillin allergy that's been confirmed in the past with skin testing, 97% will tolerate a cephalosporin and 99% of them will tolerate a carbapenem. Beta-lactam reactions can be severe, but are very rare. And the goals of an allergy evaluation are to clarify the specific risk based on available data and details of the patient's past reaction. So as a result of attending this session, what I would hope is that if someone has penicillin listed as an allergy on their chart, that you ask about the penicillin notation, follow up in the chart and see if that's appropriate. And if you're not certain, refer them to an allergist who can do skin testing if that's indicated, or an oral challenge, or both if that's indicated, so that we can get the penicillin label off of their chart. Because it's really important in the grand scheme of things. We want to consider the global importance of antimicrobial stewardship. And we know that it takes a coordinated effort from everyone to be able to promote optimal use of antimicrobial agents. So thank you very much.